Everyone, we will start our Grand Rounds webinar in just a few minutes. And while we're waiting for many of you to join, please go ahead and introduce yourself in the chat box. Hello, everyone. We will get started in just a few moments. So while you are signing on, please go ahead and introduce yourself in the chat box and let us know where you're from. Good morning, good afternoon, good evening, everyone, and welcome to our ICAP Columbia University Grand Rounds webinar entitled Intervention Approaches in Global Mental Health, Current Strategies and Future Directions. I'm Jillian Doherty from ICAP in New York, and I will be your host for this webinar today. And it's my pleasure to have all of you join us for what promises to be a very insightful and enriching discussion. As we gather here today, we're reminded of the significant strides that have been made in the field of global mental health, especially as we celebrate Mental Health Month here in May. Yet we're also equally aware of the challenges that remain. Mental health is a crucial component of overall health and well-being, impacting individuals, families, and communities around the world. The need for effective, culturally sensitive, and sustainable intervention approaches have never been more critical. In today's webinar, we will explore the current strategies being employed across different regions and contexts, highlighting innovative practices and discussing future directions. Our esteemed presenters bring a wealth of knowledge and experience, and we are so grateful for their willingness to share their insights. So without any further ado, I would like to get started. Please join me in welcoming our first speaker, Dr. Susan Michaels Strasser, who will be providing the framing remarks for our session today. Dr. Strasser is a public health professional with over 25 years of experience in nursing and public health. She is the Senior Director for the Human Resources for Health Department at ICAP, providing leadership, guidance, and direction for the development, implementation, and assessment of programs to develop human resources for health across ICAP's portfolio of programs. She has served at senior management and training levels in various locations throughout Southern Africa, and her areas of expertise include pediatric care and support, nurse training, and the use of point-of-care diagnostics. She is a pediatric nurse practitioner and a member of the Sigma Theta 2 Honor Society for Nurses. Dr. Strasser holds an MPH and MSc in nursing from Yale and a PhD in public health from the University of Cape Town. Over to you, Susan.
Great. Thank you so much, Jillian. And thank you all for being here. It's wonderful to see so many people from so many different places and from different points in my life where I've had a chance to meet with many of you. I've titled my framing remarks Mental Health, an issue whose time has come. And I'm here to provide a bit of context from my personal perspective of what we have tried to do over the last 20, 25 years to scale up access not only to HIV care, but to holistic care that will allow people living with HIV, living with a chronic, often stigmatizing illness, to live healthy and thrive and live a long life. And commingled with getting antiretroviral scale up, for me, it was obvious that mental health was a essential component of this work. I naively thought that this would be a priority for everyone, and realizing that it wasn't, and has really taken a number of people who we'll listen to today, shepherding, advocating, promoting the need for mental health alongside of access to highly active antiretroviral therapy. Next slide, please. So to achieve 95, 95, 95, it's three simple numbers, but what it takes to actually achieve epidemic control is tremendous. And most of all, it begins with a person taking their medication, knowing their status, and then taking their medication and taking that medicine each and every day. And it's one thing to have medication available. It's far different to appreciate how difficult it can be, how complex it can be to ensure that someone is able to take their medicine every day consistently to achieve viral suppression. And a lot of this comes down to our thoughts, our feelings, and our behaviors. So we must appreciate and develop programs that address the mind-body connection. Next slide. And why is it so important that we address the mind-body connection? Because we know that thoughts, what we think, what we imagine, what we perceive as concerns, leads to our emotions, our thoughts, our fears, our anxieties, our hopes, and our dreams. And our thoughts combined with our emotions lead to our behavior. And our behavior is what we do, and it affects how we think and how we feel. It's a triangle, it's a cycle. And we know that our thoughts and emotions affect our behavior. And therefore, if we are trying to change people's behavior, if we are trying to encourage a behavior where people are taking medicine each and every day, we know that thoughts and emotions are inextricably linked with our behavior. And therefore, the mind-body connection becomes very, very clear. And so we have tried, especially on personally in pediatrics, knowing that pediatrics has historically and continues to lag behind that of adults. And I really became interested in the issue of mental health, first knowing the important interplay of thoughts, feelings, or emotions and behavior. But secondly, knowing that children don't always have the full picture. They don't always have a complete understanding of why they need to take medicine each and every day. And I repeatedly heard story after story of children who were told they have chronic malaria or they have chronic TB or something else. And children maturing and beginning to question that diagnosis. Why? I know my friend had malaria and they were treated and now they're better. Why do I have something that's chronic? And children became confused and misunderstood what was going on. And clearly for me, it showed the importance of dealing with children honestly and openly, and the importance of mental health and being able to deal with the stigma and fear that parents have, and the needs of children to drive healthy behavior. So over the years, we've tried a number of things, and what we'll hear today is really the state of the art from our two guest speakers. Next slide. So there has been a mental health care evolution. All of us know that although it is still around, blame is reducing, but blame and blaming the person, well, just get over your depression, or it's something they need to step out of, was omnipresent in the world up until just a few decades ago. Stigma has always been there around mental health. Stigma of HIV combined with stigma of mental health is really a potent and dangerous cocktail. And that, lastly, reluctance on individual clients to seek mental health care, but also reluctance on donors to invest in health care. And the reluctance on the donor side has really tracked with our initial reluctance to scale up antiretroviral therapy. If you can forward, please. First of all, reluctance around money, around the personnel, who is going to be able to give this mental health therapy? How are we going to fund this mental health therapy? I've had people say to me, Susan, it's not sustainable. We can't go there. What about medicines? We don't have medicines to do this. And what we're going to learn today, that all of these seemingly reasons for reluctance really need not be there anymore. Next. And now what we are going to learn about is evidence-based mental health care that can be done efficiently and effectively in a cost-effective way by health workers through task sharing and training health workers, lay health workers with the skills and competence to do this, and making sure that mental health drugs are part of essential drug lists. Next slide. So where did we begin? I began in 2009, so many, many years ago now, thinking about what do we need to help children thrive? And we began with what we called an orphan and vulnerable children well-being tool, simply looking at what drives well-being in children. And again, it came down to two important mental health concepts: the concept of agency. Do I feel control over what I do and how I can shape my life? And then the second is pathways. Do I know how to do that? Do I have the skills, the mental health skills, the cognitive skills to navigate this world, in our case with HIV? So we began in 2009 with this. Next slide. And then from this, I went on to work with PEPFAR and AIDS Relief Program to develop a module of training for lay health workers called Psychosocial Care and Counseling for HIV-infected children and adolescents. And this was a very early, 13 years ago, attempt to bridge this chronic care mental health divide through the training of lay counselors, and had early success, but limited traction in really taking this to scale and changing policy. Next slide. And then we moved on to develop an array of services in 2014, so a decade ago, developing mental health and psychosocial services for children and adolescents in Zambia. And I titled this A Case for Learning by Doing, because there really wasn't a roadmap or a model at that point to guide us, to say this is what is needed, this is the toolkit to be used. But through the development of the curricula you just saw on the last slide, we began to introduce various components of mental health support. And again, what we will learn about today is really the evolution of this early type of work by myself and others to create a model of care that is not only appropriate and can be taken to scale, but which has been shown to be highly effective. Next slide. And then lastly, this is really a coming together of the experts on this call and a number of people in the audience to the development of what is called trauma-focused cognitive behavior therapy. And this publication, which was recently released last year in AIDS and Behavior, was work that we did through an R01 to a randomized control trial to look at the effectiveness of carrying trauma-focused CBT to the psychosocial care and counseling program that we developed in Zambia. And it's really come to a point where we've come full circle and now have, as I said, a model of care that is cost-effective, evidence-based, and can be done by the available health workforce. Next slide. Back to you, Jillian.
Wonderful. Thank you so much for those thorough framing remarks, Susan. So now I'd like to introduce our presenters for today, starting with Claire Green. Dr. Green is an epidemiologist and implementation scientist interested in identifying opportunities to improve mental health and psychosocial well-being among forcibly displaced population through multi-sectoral and community-based interventions. In her work, she consults and collaborates with governments, NGOs, UN agencies, and academic institutions. And also, please help me in welcoming Dr. Jeremy Kane, who is a psychiatric epidemiologist with research interests in global mental health, substance and alcohol use epidemiology, and adolescent health. His research investigates mental health and substance use problems among populations affected by violence and HIV in low and middle income countries, and also explores the impacts of culture and migration on mental and behavioral health among refugee and immigrant populations living in the United States. So over to you, Claire and Jeremy. Thank you.
Thanks very much, Jillian. Let me share my screen. Okay, can everyone see? Can you guys see the screen? Okay, great. Well, thanks again so much, Jillian. Thanks, Susan, for the opening remarks. Claire and I are honored to be part of the ICAP grant rounds. Having been to a few of these, they're always just so well done. So we are honored to be here. So as Jillian mentioned, Claire and I are really excited to talk to you about our work in global mental health interventions. And it's just a bit of an outline. So the idea will be to cover sort of a breadth of topics in global mental health interventions, give you a bit of an overview. So we'll start with kind of a general intro, very brief intro into global mental health itself, why the field of research and programs is necessary. We'll talk a bit about two populations for which Claire and I tend to work with quite a bit, HIV-affected individuals and migrant populations affected by humanitarian emergencies. We'll talk about some of the fundamental topics in global mental health interventions, sort of aspects that underlie most of the intervention approaches that are happening in our field currently. We'll then move into some more specific interventions, and I'll talk about what we call transdiagnostic intervention approaches with a focus on an intervention called CETA, C-E-T-A, which we have used a lot globally, and we'll provide some examples of our research with that intervention. And then Claire's going to talk about implementation approaches for interventions in global mental health. And then we'll close with kind of talking about where are the gaps in the field, where we think the field is going or where we think the field should go. But just to get us started as a starting point, what is global mental health? Why do we need a field dedicated to global mental health? It's, I think, important to keep in mind that our field is one that has truly, I think, as Susan sort of alluded to, come into its own maybe only in the last 20, 25 years or so. And really, it's been, I think, in the past 10 years where it's proliferated very quickly. It's growing very fast, lots of interest in the subject. We now have courses dedicated to global mental health at Columbia, and we have degree programs built around it at various universities around the world. And so what's on the screen is a modified version of a quote from a Lancet article written by Copeland and colleagues. This is from a number of years ago now. And in that article, they tried to come towards a consensus definition of quote, global health, right? And we modified this to include mental health. It's not a perfect definition, but I think is reasonable. And so, right, it reads an area for study, research, and practice that places a priority on improving mental health and achieving equity in mental health for all people worldwide. So we focused on that word equity, which we'll come back to in a minute. And so you've probably heard this before, right? There is no health without mental health. It was a sentiment first expressed way back in 1954 by the first Director General of the WHO. And what the graph on the left of the screen shows is that a substantial percentage of DALYs particularly among younger and middle-aged populations, but also throughout the life course, are attributable to mental health and substance use disorders. They are a big, big driver of the global burden of disease. And the graph on the right shows the burden of mental health and substance use disorders overall has been increasing over the past 30 plus years. So there's a considerable burden globally. That burden is increasing. We say that there is no health without mental health. And yet, right? And yet, in low and middle income countries in the global south, it comprises over 80% of the global population, but have less than 20% of the mental health resources. Approximately, on average, 1% of health budgets in the region are dedicated to mental health. And there is an absolutely enormous treatment gap where about 90% of persons with a mental health or substance use problem living in a lower middle income country do not receive adequate care for those mental health problems. 75% essentially receive basically no care at all. So to put it simply, right, this is the definition of inequity, which is why we think a dedicated field of global mental health is necessary. And of course, it's not a small problem that we face. Mental health problems are incredibly prevalent. In 2019, 1 in 8 people, that's about 970 million, so we are fast approaching 1 billion people who are living with a mental or behavioral health disorder, most commonly depression, anxiety, PTSD, and substance use disorders. So mental health touches everyone, right? So in large part, our field is working to close that treatment gap in low and middle income countries overall. But having said that, there are a few key populations for which at least we tend to focus our work. And the first of these is among populations in humanitarian settings, including displaced, mobile, and migrant populations. So the vast majority of wars, conflicts, natural disasters, refugee and displaced person crises are in low and middle income countries. Humanitarian settings such as these can contribute to mental health, alcohol, and substance use problems. And being that humanitarian settings are predominantly in LMIC, they are also, as we mentioned, where the fewest mental health resources are. Currently, there are approximately over 108 million people forcibly displaced worldwide. It's a remarkable number, a record number that sort of continues to grow. And so we'll provide some examples of our work with populations impacted by humanitarian emergencies a bit later. And the second population we wanted to highlight is one, of course, familiar to many of the folks on this call, populations affected by HIV. So what we put on the screen are pooled prevalence estimates for depression, anxiety, PTSD, alcohol use, and other substance use among people living with HIV. These are from 5 meta-analysis papers. And so, sort of in summary, relatively high rates of all of these across the board, almost suggesting that basically about a third, at least a third of people living with HIV are experiencing at least one of these problems, if not more. And there have been studies to show that improving mental health and alcohol and substance use problems among people living with HIV can subsequently improve HIV outcomes. So this is, again, why we consider HIV-affected populations to be a priority when it comes to mental health. Okay, so that's sort of a very brief intro. And so we now wanted to spend a few minutes providing some information on like fundamentals of mental health intervention approaches in our field. And so, you know, in our work in global mental health, there are now a rather large number of different psychosocial and psychological interventions that are used. You may have actually heard of some of them. You know, the Friendship Bench, for example, has been in the popular media quite a bit. Problem Management Plus, PM Plus, has been sponsored by the WHO. CETA, which we'll be talking about in more detail in a second, but there's actually many, many more. TFCBT, which Susan mentioned at the top of the hour. So there's a lot of these, but underlying most of them anyway are sort of several fundamental aspects that we think are important to recognize when thinking about the field. So first, one important aspect to keep in mind is that the manifestation of mental health problems is not singular, right? So yes, research has shown that depression in some form exists everywhere in the world. But how that depression is understood, how that depression is described by people, can be influenced by many factors, including culture. So a cognitive behavioral therapy manual pulled off the shelf without proper cultural adaptation is likely to have very limited ability to impact something like depression if that manual has not been properly adapted to address the types of depression symptoms that are often experienced and presented in a particular population. And you see some of these kind of culturally specific depression-like symptoms on the screen here, right? So understanding cultural concepts of distress and cultural adaptations of mental health interventions is an important fundamental aspect of our work, regardless of which of those interventions you're trying to pilot or implement or test or whatever. Next, we talked about how so few resources are available to be dedicated to mental health services. So one consequence of having so few resources available to address mental health in low resource contexts is that there are very few highly trained mental health providers in those settings, right? So this is probably the most well-known, the most talked about supposed barrier to mental health interventions in our field. And so to address this, again, Susan alluded to this as well, another fundamental of global mental health interventions is that they often use a task shifting or a task sharing approach, something I'm sure many of you are familiar with in your work in HIV or other sectors, right? So task shifting involves the redistribution of tasks from highly qualified health workers to health workers with shorter training and fewer qualifications. And so, practically, what does this mean? It means that in our work, in almost all the intervention studies and programs that you'll read and that we'll talk about today, nearly all of these interventions are provided through a task shifting approach in which the interventions are provided by lay counselors, right? In other words, they're not provided by psychiatrists or psychologists or clinical social workers. They're provided by people who are not mental health experts. So how does the task sharing or task shifting work practically? How do lay counselors actually have the ability to provide evidence-based effective mental health interventions? So we often, in our work, we often use a model of training lay counselors called the apprenticeship model. And so the idea here is that you have sort of expert trainers. And so those folks typically are psychiatrists or psychologists or clinical social workers. And they provide an intensive training and coaching to lay counselors on a particular intervention. Among the counselors who are being trained, those who are particularly highly qualified and show lots of promise are chosen to be clinical supervisors. And so those individuals also receive additional training by the expert trainers, not just on the counseling itself, but also training on how to be supervisors, right? So we have sort of three tiered levels here. You have clients who are receiving treatment by the lay counselors. The lay counselors are supervised by the supervisors who provide quality control. And the supervisors also receive supervision by those expert trainers on a regular basis for additional levels of quality control. And of course, a natural extension of this apprenticeship model is something you might also be familiar with, a train-the-trainer approach, where the goal is for these expert trainers to train counselors on how to become trainers themselves, and so that this model can sort of perpetuate over time. Okay, so with some of those fundamentals in mind, we're going to talk about a specific type of mental health intervention that has become much more popular recently in our field. Those are called transdiagnostic approaches. And specifically within those approaches, an intervention we have used quite a bit, CETA, which is short for the Common Elements Treatment Approach. So a really important thing to keep in mind when thinking about mental health interventions that I don't think gets talked about enough is that among people who have a mental health or an alcohol or substance use problem, having more than one mental health or alcohol or substance use problem is really common. So common, in fact, that it often should be considered the rule, not the exception. Our own epidemiologic research across a number of studies in Zambia has shown that among participants presenting with a mental health or a substance use problem, over 50%, over half, had more than one presenting problem. And I think that comorbidity, or at least the way that we address or don't address comorbidity, is actually a contributor to the treatment gap that we talked about at the beginning. And so, why is that the case? I think it's the case because despite that reality of comorbidity, the high prevalence of comorbidity, mental health systems are not designed to address it, right? Our health systems are not set up to address overlapping or co-occurring conditions. What we have found in most cases is that substance use, mental health problems are instead thought about and treated and even, frankly, funded by funders sort of separately, one at a time, in silos, right? So we have a silo for substance use, we have a silo for depression, we have a silo for PTSD, we have a silo for alcohol use. And so that's a problem, right? So it brings us to CETA. So CETA, again, short for Common Elements Treatment Approach, was developed in part to address this reality of comorbidity. So CETA features many of the aspects I just talked about: cultural adaptation, task shifting, an apprenticeship model, and is a counseling delivered by lay counselors. What we mean by transdiagnostic is that CETA is built as a modular program that has the ability to address multiple problems, so including PTSD, depression, anxiety, substance use. And so the way this works is that counselors work with their supervisors to choose appropriate evidence-based elements that you can sort of see here on the screen based on a client's needs and symptom presentation. So for example, behavioral activation is an evidence-based therapeutic element for depression treatment. So for a client who presents with depression, a counselor would likely choose to use that element as part of the client's treatment package. So, in that way, CETA is designed to be kind of customizable and adaptable to the needs of a client. It's typically delivered over between 6 and 12 weekly 1-hour sessions. But again, there's some flexibility built in depending on symptom presentation and severity. And so we think that this flexibility is sort of one aspect that kind of sets the intervention apart from some of the other interventions I put on the screen earlier, which are a bit more rigid in terms of structure and number of sessions and things like that. But again, the idea here with the transdiagnostic therapy is to remove those silos and then equip this lay provider, this lay counselor, with the ability to treat a range of potentially co-occurring problems at the same time. And so here you see, this is a CETA training happening in Zambia, training being led by our colleague David Mwanza, who was originally trained as a CETA counselor and now has become one of the most experienced CETA experts in the country and is a certified CETA trainer. CETA has been tested in a number of studies, mostly randomized controlled trials, and also used in programs as well around the world. I've highlighted a few here. You can see sort of a diversity of samples, contexts, and populations. In basically all instances in the trials, CETA has been effective from a statistical significance perspective, typically with medium to large effect sizes compared to control conditions at improving the primary outcome in those studies, which has, again, ranged from depression to anxiety to PTSD to unhealthy alcohol use to even IPV, intimate partner violence. And so we're just going to kind of run through rapid fire results and description of 3 CETA studies from Zambia, where we've done a lot of work over the years. Actually, Claire and I are just back from Zambia over the weekend. So this will be super quick, just to give you a flavor of these CETA studies. But of course, we're happy to answer questions, send you papers, reports, or talk to you individually in the future if you're interested in this. So this first trial I wanted to highlight is very hot off the press. We have not submitted the paper yet. So this, we just finished it. So this was a community-based trial in and around Lusaka, where we enrolled 400 adolescents and young adults, 15 to 29 years old, who met symptom criteria for at least one of PTSD internalizing problems. Internalizing problems includes depression and anxiety, and or externalizing problems. Externalizing problems are things like aggression, disobeying rules, things like that. It was a 3-arm trial where adolescents were randomized to receive CETA counseling as it normally is delivered in person, or they received a telephone-based CETA, which is basically CETA delivered, but over the phone. We called it T-CETA. Or they received treatment as usual, which in this case in Lusaka was some very basic sort of ad hoc counseling that is, sort of intermittently delivered and available at local organizations. We measured outcomes at post-treatment and a 6-month follow-up. And you can see a similar trend across these 3 graphs here in the 3 outcomes, right? So the red line is the mean outcome scores for the control, treatment as usual participants. The black line are T-CETA participants. The blue line are CETA participants. And so across all 3 outcomes, we found that both CETA and T-CETA were significantly superior to the control condition in reducing PTSD, externalizing problems at both follow-up time points. So this was, this is really encouraging, we thought, for at least 2 reasons. First, the adolescent global mental health literature, unfortunately, is relatively thin compared to adults. And the interventions that have been tested so far, have had somewhat mixed, somewhat disappointing results, to be honest. And so to see pretty big effect sizes here is promising. And then second, the use of a telehealth version of CETA. We had no idea how it was going to go. The first time this has been done, and we think it shows significant promise. Although reductions in symptoms were larger in the in-person CETA group than the T-CETA group, those differences were not statistically significant. So yeah, we're excited about the potential for a telephone-based intervention as well, which was actually not part of the original trial design. It was something that we added in almost on the fly after the onset of COVID back in 2020. So then the next 2 trials I'm going to run through briefly, both have a primary outcome of unhealthy alcohol use. And so for these trials, the idea was to build more of a system of care around the CETA intervention. And for those of you who are familiar with alcohol or substance use treatment, a popular type of care model, at least here in the US, has been what's called the stepped care model, and specifically what we call SBIRT, S-B-I-R-T, which stands for screening, brief intervention, and referral to treatment. So 3 steps to this system of care. First, a validated alcohol screening to measure the presence and severity of alcohol or mental health problems. Second, the provision of a brief intervention, which is 1 40-minute session intervention we developed based on CETA, specifically to address unhealthy alcohol use. And then the third step, if necessary, is a referral to the full CETA therapy, again, which is about between 6 and 12 sessions. And that last step is typically reserved for individuals with the more severe problems, right? So unhealthy alcohol use plus mental health comorbidities, for example. And so this sort of represents a stepped care approach to treating alcohol and substance use problems. So we tested this package of care in 1 completed and 1 ongoing randomized trial. The first one we have published, also in AIDS and Behavior, actually. It was called the ZCAP trial, Zambia CETA Alcohol Pilot. And this was done within HIV clinics in Lusaka. And in that trial, we tested the stepped care package that included that brief intervention plus the full version of CETA. And the results were interesting, right? The main takeaways were that among people living with HIV who had unhealthy alcohol use, but had no other mental health or substance use comorbidities, that brief intervention, that 40-minute brief intervention session by itself was pretty effective at reducing their unhealthy alcohol use. But for individuals who had 1 or more mental health or other substance use comorbidities, the brief intervention followed by CETA was necessary for them to improve symptoms. So the pilot trial results basically supported our hypothesis that a stepped care package where individuals receive a level of care that is commensurate with their symptom severity or complexity was really effective in this HIV care setting. And so if you're wondering whether those improvements in alcohol and mental health translated into better HIV outcomes, we didn't measure that in the pilot, but we currently have an ongoing pretty big RCT, 700-person RCT in Lusaka, where we're testing just that, whether this intervention package can help to improve sort of downstream HIV outcomes, including viral suppression, retention, et cetera. Okay, so last thing I'll talk about before turning over to Claire So based on those ZCAP pilot results from Lusaka, we thought the results showed strong potential for this intervention approach for alcohol, substance use, and mental health. And when you look at global mental health in humanitarian settings and among migrant populations, one of the biggest gaps has been in studying interventions for alcohol and substance use problems. In fact, in a review that Claire and I did for UNHCR a few years ago, we found that there were really zero rigorous randomized controlled trials with substance use as a primary outcome in refugee camp settings that had been done. So we thought this could be an excellent opportunity to test our stepped care package featuring that brief intervention and CETA in a humanitarian setting. And so this is the purpose of an ongoing trial that we have in northern Zambia. We're just back from there again a few days ago. So the location of the study is in what's called Montapala Refugee Settlement, which opened in 2018. It's located in the very far northern province of Zambia, right on the border with DRC. When we started in 2020, Montapala was hosting over 20,000 people of concern from Democratic Republic of Congo. There were also about 5,000 Zambians who live in the area as part of the host community. The number of people in the settlement has fluctuated over the years, with some repatriating back to Congo, some arriving from Congo. We've just received word that there could be another big influx of individuals in the coming months, but we're a bit uncertain about that. So it's very different than working in the HIV clinics in Lusaka, right? It's a very kind of dynamic situation. So we can't share any results from the study in terms of the intervention effectiveness of the stepped care package. The trial is ongoing. We'll have results early next year. Happy to come back and share those. But we do have baseline data that we can share so far. And I just wanted to do this quickly because it illustrates, again, how in two very different populations, right? On the one hand, HIV clinics in Lusaka, on the other hand, in a refugee camp on the DRC border. In both cases, we see incredibly high rates of mental health comorbidity. So everyone in our study had unhealthy alcohol use by nature of the study design. But among them, 85% had depression as well, 47% had PTSD as well, 44% had anxiety as well, and 33%, a third, had used an illicit substance in addition to alcohol. Only 13% had no comorbidities in addition to the unhealthy alcohol use. 24% had one comorbidity, 30% had two comorbidities. And then again, one third of our participants had three or more comorbidities in addition to the unhealthy alcohol use. So a very affected sample. I'll wrap up here. So just a quick summary. Given the high rates of comorbidity, a transdiagnostic approach like CETA, particularly when used within something like a stepped care model, we think can be a much more efficient and effective approach than single disorder treatments. We are encouraged by the CETA intervention. There is now a large amount of accumulating evidence on its clinical effectiveness, particularly given that it's been effective in such an array of populations. It's a big but, right? We have to figure out a way to better implement the interventions. CETA, to be honest, is not in wide use outside of research studies, nor are really many of the other interventions being used in global mental health research. And so we need, as a field, to start thinking about establishing more sustainable, impactful systems of care. Okay, with that, Claire, I will turn over to you.
Sure. Thanks, Jeremy. And I will zip through these because I know we're running quite short on time. But as Jeremy mentioned, the evidence supporting the effectiveness and feasibility of these types of intervention models is really growing. But as Jeremy said, there remains this disconnect between what we know works and what's being implemented in practice. So in the next few slides, I'm going to share a couple of examples of ongoing implementation studies that really aim to test new approaches that may overcome some of the barriers to access and implementation of evidence-based mental health interventions. Next slide. So the examples I will present come from our work in Latin America with a focus on refugees, migrants, and asylum seekers. And just for context, and there are likely people on the call who know this even better than us, but Latin America has experienced one of the greatest regional increases in migration within the last decade. As shown on the left, migration patterns as well as the reasons for migration are quite complex, dynamic, and heterogeneous. Most of the work that we have been doing has been primarily with migrants who have fled the economic and political crisis in Venezuela. But it's really important to acknowledge that there are a lot of countries of origin represented among migrants within this region, including migrants from other countries within Latin America, but also migrants arriving from Asia, the Middle East, Africa, and Eastern Europe. With regard to migration from Venezuela, there are now approximately 7 million migrants who have left Venezuela since about a decade ago, which is almost a quarter of their population. And Colombia and Peru remain the primary host countries for refugees and migrants from Venezuela, meaning that the majority of these refugees and migrants are staying within the region. Next slide, please. So since 2020, we have been working with an NGO in a few countries in Latin America, in Panama, Colombia, Ecuador, and Peru. And this NGO provides a range of protection and health services, including community-based mental health and psychosocial interventions for refugees, migrants, and host communities along some of these key migration routes and destinations within the region. And the first 3 studies that we conducted were evaluations of 3 different mental health interventions that are listed at the top of this table here, and some of them Jeremy mentioned earlier in the presentation. I won't go through them in detail now, but happy to answer questions at the end. But what I think is important just to note is that all of these share some of the features that Jeremy described that are common to global mental health interventions. They all employed a task shifting model with refugees and migrants serving as the intervention providers. And they all aimed at improving one or more aspect of mental health and psychosocial well-being through social, emotional, cognitive, and behavioral mechanisms. Next slide. So after completing these 3 initial studies, we conducted a pooled analysis of the data from approximately 400 refugees and migrants who engaged in some way in these intervention studies to explore their experience and the challenges that they faced in participating in these interventions. And what we saw was that 25% of people who were enrolled, meaning that they were eligible and expressed interest in participating in these interventions, never actually attended a single session of what are multi-session mental health interventions. And even among those who started one of these mental health interventions, 23% didn't actually complete the intervention. So we were really interested in understanding what was explaining some of this dropout, and what we ultimately discovered was that populations who were in more unstable or vulnerable circumstances, and also likely those who have the greatest need for mental health supports, were the ones who were not engaging or remaining engaged within these interventions. And a few key subgroups that are relevant for the next couple of slides are listed here. So we found that migrants who lacked formal employment or a reliable source of income, those who were mobile or in transit or actively migrating, as well as those who were more distressed and had lower levels of functioning, were actually the least likely to initiate or kind of stay engaged with these interventions. And to us, this really signaled the need to tailor mental health interventions and how we implement them to the most vulnerable and hard to reach groups to hopefully mitigate some of these barriers to participation and promote equitable access for those in greatest need of mental health support. Next slide. So I'm going to very quickly run through just a couple of examples of some strategies we've used to try to overcome these barriers to engagement. The first example is trying to address the challenge of insecure livelihoods as a barrier to participating in mental health programs. And we've tried to do this by actually integrating mental health with economic programs for refugee and migrant families in Ecuador. And the second is using participatory methodologies to really rethink how we implement and how we design mental health interventions for migrants who are in transit along key migration routes in Colombia, which hopefully will address that barrier related to population mobility I mentioned on the previous slide. Next slide. So as I mentioned before, this barrier of not having a formal job or reliable source of income has not only came up in this analysis, but has come up in almost every global mental health study I've worked on. And the rationale and what we think is underlying this is that we know that mental health and poverty are very much interconnected. But also from a more practical perspective, often refugees and migrants are forced to weigh the trade-offs between spending their afternoon participating in a mental health intervention or using that time to find work and meet their basic needs. The quote on the right, I think, really nicely illustrates this trade-off, so I'll read it quickly. This is from one of our participants in our first study in Ecuador, and she says, "I can't take the day off to attend because I can't pay rent. I'm a single mother. I just live with my baby daughter and my son. NGOs do help me with the food card, but I have to pay for my baby's diapers. I'm very busy, so sometimes I don't come to the intervention. I start selling cold cakes and stuff at home, and I go out to sell any little thing. I can't stop working." So in this project, we tried to see if we could reduce the need to decide between efforts to promote livelihoods and promote mental health by integrating these programs together. Next slide. We worked with an NGO that provided a range of community-based mental health and psychosocial interventions, which are listed on the left-hand side. And through an extensive formative research process with refugees, migrants, and NGO staff, we designed a set of implementation strategies to integrate these mental health elements into an existing economic intervention called the Socio-Economic Support Program, or CESP, which is based on the graduation model for those who might be familiar. The CESP is an intensive poverty alleviation intervention for families that lasts up to 15 months. And in this intervention, families who are in extreme levels of poverty receive cash assistance, a range of social protection services, financial literacy training, and different skills training to promote employability and entrepreneurial skills. They also receive monthly home visits by NGO staff to track their progress against a set of financial and economic indicators. And so we worked in 2 field sites within Ecuador in Quito. In one of these sites, the NGO implemented their mental health services and the CESP program as they normally do, which is largely separate and siloed, perhaps with some referrals between these 2 programs. And then in the other site, we implemented this integrated approach where aspects of these mental health interventions were actually incorporated into the CESP program. And some of the mental health staff, like psychologists, worked directly with the families who were enrolled in the CESP program throughout their participation. Next slide. So our 6-month data actually just came in today, so we haven't analyzed it yet, but on this slide, I'm showing you the results from baseline to 3 months follow-up. And what we saw is that compared to the implementation as usual approach, which is shown in blue, where the economic and mental health services were implemented separately, we actually saw a greater reduction in depressive symptoms, anxiety symptoms, and functional impairment among the families that received this integrated approach, which we think is quite promising. And we also saw higher levels of engagement and retention in the site where the integrated model was implemented. Next slide. So the second example tries to address that challenge of population mobility, which is another important barrier to engaging and staying engaged in mental health interventions. And in this project, we're working with migrants and asylum seekers in shelters along key migration routes in Colombia. One of the challenges is that migrants are only permitted to stay in these shelters for 2 to 3 days before they're required to move on, which makes continuity of care and providing any of the multi-session scalable interventions that Jeremy presented earlier quite difficult to implement safely and appropriately. So we are using now a range of participatory methodologies to work with migrants within these shelters in different locations within Colombia to design and prioritize different strategies to improve implementation of mental health interventions during this period of transit, which in this context can last months to years. Next slide. So we are still in the very early stages of this project, but so far there are some interesting strategies emerging that I just wanted to mention. And of course, if people are inspired by any of this, please share your thoughts or ideas with us during the Q&A. So first, we found that access to information and access to reliable information is something that migrants have repeatedly said would not only help them know how and where to seek mental health support along the migration route, but could also directly alleviate some of the uncertainty and anxiety they face as they proceed along these routes that we know can be quite dangerous. Also thinking creatively about where we provide mental health supports and how we connect them with other types of services may also improve engagement and care. And then on the right-hand side are some strategies to promote continuity of support, which include things like strengthening the regional coordination across different actors and organizations so that migrants don't have to start all over with sharing their history, their experiences, and restarting care as they migrate to new locations. Other platforms like telephones may also help maintain engagement and care But so far, access to phones and access to the same phone and same phone number has been something that we found quite challenging. And then also thinking about family-based interventions that address the needs of the entire family. Migrants who reported would help motivate them to continue to seek out support as they migrate. So this is work that's still in progress, but we hope to operationalize a strategy really specifically tailored to this vulnerable and at-risk population later this year that we will be pilot testing within these shelter networks. Next slide. All right. I will be very brief here because I know we have just a couple minutes, but just to wrap up, I wanted to share a few key areas, just 2 key areas that we see as important next steps. And the first is that we really need to improve the population level mental health epidemiological data that we have by incorporating mental health indicators into some of the population-based surveys, which can also help us monitor different trends and potentially understand some of the broader community effects of these different mental health and targeted mental health interventions. And then second, from the implementation perspective, there's a large area of future research that's needed to help us overcome some of the barriers to implementation and to impact. And some of the ideas we've shared today about how to do this include integrating mental health services into different systems of care, tailoring mental health interventions for key populations, and promoting the use of implementation research and collaborations to advance knowledge on how to translate this research into practice. So our final slide, I think, is just a thank you. And thank you all for your attention. And we're happy to take a couple questions if we can.
Thank you so much, Claire and Jeremy. That was a really excellent, comprehensive presentation. I see one question, and I'm gonna add to the question. Is the question from Stephen is the first one to come in, where he seems to be highlighting the challenge that Claire, you also spoke quite a bit about of retention. In like multi-session mental health interventions, right? Because so many clients have so many sort of competing life factors, and it's very complex to maintain retention. And I'm just curious, sort of, you know, in terms of future directions, where you see digital or telehealth solutions, and how you see technology shaping the future of these interventions that you both discussed. Over to you. Either Claire or Jeremy.
Sure, I can quickly start and then hand it to Jeremy. I mean, it's a really good question, and it's like the one that's at the top of my mind all of the time now. I mean, I think there is an emerging area of single session interventions, but I don't think those are going to address, especially some of the more severe forms of mental disorders and mental health problems. So I don't think they're sufficient. I think we need to be very creative about how we think about mental health. And I'm very interested in exploring more opportunities of how to position mental health into other services that people are accessing and are addressing some of those other competing priorities instead of having people need to decide between them. I think technology keeps coming up, and I think it is really promising. I think, and we've done some pilot work, for example, our project in Peru used telephones to deliver the intervention we tested with migrants. I think my fear is that still some of the most, I think, vulnerable and people in greatest need are probably those that will have the least reliable access to that technology. So I worry, I think it is a good solution, but I don't think we can put all of our eggs in that basket until we can ensure that we're not driving disparities even wider. Jeremy, do you have anything?
Yeah, and there's been such a quick move to telehealth out of necessity during COVID, but I think it's happened very quickly. And I think the evaluation of how well it works is not quite there yet. So the quick slide I presented here did show some promise of T-CETA, of telehealth CETA. But digging into that data a bit more, which we didn't have time to do today, when we look, we're still exploring this, so this is sort of preliminary, but when we look at the adolescents who had pretty severe PTSD, it did look like actually the in-person CETA might be superior to T-CETA among that sort of very specific subgroup. But these are the types of things that we need to investigate further, because there's been such a quick movement to say it's just as good for us to be able to do this stuff virtually. And for some things and some problems and some levels of severity, that might be true, but not for others. And so I think we just need to be very careful before we go and truly, you know, advocate and say this is going to be equivalent or not inferior to in person. Because I think overall we just don't know yet. And then there's also the cultural aspect of it. We had no idea how well TCDA would work among adolescents in Zambia. There's not really a strong culture of talking on the phone for a long period of time, and also not having that in person, having that connection to a counselor. And so we have a bunch of qualitative data we still have to go through. But some of the early indications were, you know, the adolescents said it was okay, but they really would have preferred if they could even have one session, just like one introductory meeting with a person who's going to be, you know, who they're going to be telling these really intimate things to, and have these really intense conversations with. So, you know, it's inevitable that telephone delivery and technology is going to be there, but we need to make sure we do it carefully and that we evaluate it properly.
Yeah, great answer. Susan, I see your hand up. Are you able
Yeah,
to,
just quickly,
okay.
Stephen had a comment about self-screening apps. I don't know about self-screening apps, but there is a online service out of Australia called Mood Gym, which also uses principles of TFCBT that I am aware of. And then there was one other comment about bringing this, really looking at the durability of mental health interventions and how to keep people, retain people in care. And for me, my only comment there is integration, really integrating mental health services into all aspects of care, well child care, chronic care, well person care, and making it part and parcel of our service delivery. And Wafa has a comment with regards to CETA. ICAP is scaling CETA in a province in Mozambique. In terms of your findings, it might be worth it to use a slightly less effective intervention if that would achieve greater scale up, i.e. reaching more individuals.
Yeah.
Thanks, Jillian.
Thank you. I just want to read Michael's question, and then we can wrap up this session. I know we're going in just a few minutes over, but I think it's really important. Thanks for the excellent presentation. Retention in NPHSS care appears significant significant phenomenon. The context of integration with HIV treatment services, what should be the recommendation on the approach? It's a big question. Beyond 12 months is independently challenging. So I'll hand over to either one of you.
Claire, do you want to take a shot?
I don't think I can comment on the HIV context. So I don't know if Jeremy, maybe that's better position for you.
No, I mean, I think so. So the question was about how can we retain people beyond 12 months? Is that what is Jillian? Is that the
Yeah, yes, exactly.
Yeah, so the answer is I don't know. And obviously we won't be able to really get into it in the short period of time we have left. One thing though that I would say is we need to study it better. And this is another kind of gap in our fields. You know, Claire mentioned a few of them, but 12 months, if you look at our intervention studies, at best, we have 12 months of follow-up at best. In most of our studies, most of our trials, we do a post-treatment. Maybe we'll do a 6-month. And then in a fewer, we do 12 months. So it's really hard for us to know right now across any of these interventions, how long if we have effects, how long they're sustained for, when people might need additional services, when they need additional treatment, you know, when people might get sort of lost to follow up beyond 12 months. All those things are really open questions that are really important for us to answer. And so we've been advocates for a long time for longer studies and longer follow-up periods. It's hard to get those types of things funded, but it's really important for us to do from both a clinical perspective and from a systems perspective. So I think that should be a priority of ours.
And I know I said I had nothing to add here, but I actually just wanted to mention one thing, which is I think there's a lot of value in the kind of social dynamic as well. And we found that when there is some sort of group element or peer support element to these, people tend to want to stay engaged. And so I think if there's a way you can embed and leverage kind of the community building and community ownership of these programs, I think it can support longer term engagement.
Yeah, that's a great point. And thank you, Michael, for that great question around really around our future directions. So thank you both to our great presenters, and thank you, Susan, for your remarks. We'll conclude our webinar, and then we'll share the slides on the ICAP website. Thank you, everyone.
Thank you, Jillian. And our next presentation is up for June 25th on MPOX. Thank you all.
Thanks, everyone.